Drug dosing in renal failure. Renal failure significantly alters drug pharmacokinetics, necessitating dose adjustments to prevent toxicity. The Cockcroft-Gault equation is a widely used method to estimate creatinine clearance, guiding drug dosing in renal impairment. Accurate dosing is crucial to maximize efficacy and minimize adverse effects in patients with renal failure. Key points. Note: the Cockcroft-Gault equation estimates creatinine clearance, CrCl, using the formula CrCl ml/min equals 140 age, weight, kg, /72 serum creatinine, mg/dl, for males, and 85% of this value for females. A CrCl of 60 ml per minute or less indicates impaired renal function, requiring dose adjustments for many medications. The National Kidney Foundation defines chronic kidney disease, CKD, as a glomerular filtration rate, GFR, less than 60 ml/min/1.73 m², or the presence of kidney damage for 3 months or more. The American Heart Association, AHA, recommends using the Cockcroft-Gault equation to estimate CrCl for drug dosing in patients with renal impairment. For patients with a CrCl of 30 to 50 ml/min, the dose of metformin should be reduced by 50%, and for a CrCl less than 30 ml per minute, metformin is contraindicated. The World Health Organization, WHO, recommends a maximum dose of 2 grams per day of acetaminophen in patients with severe renal impairment, CrCl less than 10 ml per minute. The European Society of Cardiology, ESC, suggests that the dose of beta blockers, such as metoprolol, should be reduced by 50% in patients with a CrCl of 10 to 30 ml/min. Overview and epidemiology. Renal failure, either acute or chronic, is a significant clinical condition that affects a substantial portion of the population. Chronic kidney disease, CKD, is defined by a glomerular filtration rate, GFR, less than 60 ml/min/1.73 m², or the presence of kidney damage for 3 months or more. The prevalence of CKD is approximately 10 to 15% in the general population, with higher rates in individuals with diabetes, hypertension, and older adults. The incidence of acute kidney injury, AKI, is also significant, affecting up to 20% of hospitalized patients. Major risk factors for renal failure include diabetes mellitus, hypertension, family history of kidney disease, and older age. Understanding the epidemiology of renal failure is crucial for early detection and management, as it can significantly impact patient outcomes and quality of life. Pathophysiology. The pathophysiology of renal failure involves a complex interplay of factors that ultimately lead to a decline in renal function. In CKD, the kidney's ability to filter waste products and excess fluids is gradually impaired, leading to a buildup of toxins in the body. This can result from various causes, including diabetes, hypertension, and glomerulonephritis. The molecular basis of renal failure involves alterations in renal hemodynamics, inflammation, and fibrosis. As renal function declines, there is a decrease in the glomerular filtration rate, GFR, which can lead to electrolyte imbalances, fluid overload, and acid-base disturbances. The progression of renal disease can be slowed or halted with early intervention, including tight blood pressure control, glycemic management, and avoidance of nephrotoxic agents. Clinical presentation. The clinical presentation of renal failure can vary widely, depending on the underlying cause and severity of the disease. Symptoms may include fatigue, weakness, shortness of breath, and swelling in the legs and feet. Physical signs can include hypertension, edema, and signs of fluid overload, such as jugular venous distension. Atypical presentations can include symptoms related to electrolyte imbalances, such as muscle cramps, weakness, and cardiac arrhythmias. Red flags for renal failure include a rapid decline in renal function, severe electrolyte imbalances, and signs of uremia, such as pericarditis and encephalopathy. Diagnosis. The diagnosis of renal failure is based on laboratory criteria, including a serum creatinine level greater than 1.2 mg per deciliter for females and 1.5 mg per deciliter for males, or a GFR less than 60 ml/min/1.73 m². The Cockcroft-Gault equation can be used to estimate CRCl, with a value less than 60 milliliters per minute indicating impaired renal function. Laboratory workup should include a complete blood count, electrolyte panel, and urinalysis to evaluate for signs of kidney damage or disease. Imaging studies, such as ultrasound, may be used to evaluate kidney size and structure. Scoring systems, such as the modification of diet in renal disease, MDRD, study equation, can be used to estimate GFR and stage CKD. Management and treatment. First-line therapy for renal failure involves management of the underlying cause, such as tight blood pressure control and glycemic management. For patients with a CRCl of 30 to 50 ml/min, the dose of metformin should be reduced by 50%, and for a CRCl less than 30 milliliters per minute, metformin is contraindicated. The dose of other medications, such as beta blockers and ACE inhibitors, may also need to be adjusted based on renal function. Second-line options for managing renal failure include the use of diuretics, such as furosemide, to manage fluid overload, and the use of erythropoiesis-stimulating agents to manage anemia. Special populations, such as pregnant women and patients with hepatic impairment, require careful consideration and dose adjustment. The AHA and ESC recommend using the Cockcroft-Gault equation to estimate CRCl for drug dosing in patients with renal impairment. The National Institute for Health and Care Excellence, NICE, guidelines recommend that all patients with CKD should have their renal function monitored regularly, with adjustments made to medication doses as needed. Complications and prognosis. Complications of renal failure can include electrolyte imbalances, fluid overload, and uremia. The incidence of these complications can vary widely, depending on the underlying cause and severity of the disease. Prognostic factors for renal failure include the underlying cause, severity of disease, and presence of comorbidities. Referral criteria to a nephrologist include a GFR less than 30 ml/min/1.73 m², or the presence of signs of uremia or electrolyte imbalances. Special populations and considerations. Pediatric patients with renal failure require careful consideration and dose adjustment of medications, as their renal function is still developing. Geriatric patients may require dose adjustments due to age-related declines in renal function. Pregnant women with renal failure require careful monitoring and management, as renal disease can increase the risk of adverse pregnancy outcomes. Patients with comorbidities, such as liver disease, may require dose adjustments due to altered drug metabolism. Drug interactions can also occur in patients with renal failure, and careful consideration should be given to potential interactions when prescribing medications. Clinical pearls. Note: the Cockcroft-Gault equation is a useful tool for estimating CRCl and guiding drug dosing in patients with renal impairment. A CRCl of 60 milliliters per minute or less indicates impaired renal function, requiring dose adjustments for many medications. The dose of metformin should be reduced by 50% in patients with a CRCl of 30 to 50 ml/min, and contraindicated in patients with a CRCl less than 30 milliliters per minute. Patients with renal failure are at increased risk of electrolyte imbalances and fluid overload, and require careful monitoring and management. The AHA and ESC recommend using the Cockcroft-Gault equation to estimate CRCl for drug dosing in patients with renal impairment. Patients with CKD should have their renal function monitored regularly, with adjustments made to medication doses as needed. The NICE guidelines recommend that all patients with CKD should have their renal function monitored regularly, with adjustments made to medication doses as needed. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.